Diseases of Ear, Nose and Throat and Head and Neck Surgery by P.L. Dhingra. Chapter 6, Assessment of Vestibular Functions. Assessment of vestibular functions can be divided into two groups. 1. Clinical tests. 2. Laboratory tests. Clinical tests of vestibular function. A. Spontaneous nystagmus test. Nystagmus is an important sign in the evaluation of vestibular system. It is defined as involuntary, rhythmical, oscillatory movement of eyes. It may be horizontal, vertical, or rotatory. Vestibular nystagmus has a slow and fast component, and by convention, the direction of nystagmus is indicated by the direction of the fast component. Intensity of nystagmus is indicated by its degree. How to elicit and interpret? To elicit nystagmus, the patient sits at the front of the examiner or lies supine on the bed. The examiner keeps his finger about 30 cm away from the patient's eye in the central position and moves it to the right or left, up or down, but does not move it at any time more than 30 degrees from the central position to avoid gaze nystagmus. The presence of spontaneous nystagmus always indicates an organic lesion. Vestibular nystagmus is called peripheral when it is due to lesion of labyrinth or eighth cranial nerve, and central when the lesion is in the central neural pathways, vestibular nuclei, brainstem, cerebellum. Irritative lesion of the labyrinth, serous labyrinthitis, causes nystagmus to the side of the lesion. Paretic lesions, purulent labyrinthitis, trauma to labyrinth, section of eighth nerve cause nystagmus to the healthy side. Nystagmus of peripheral origin can be suppressed by optic fixation by looking at a fixed point and hence enhanced in darkness or using Fresnel glasses plus 20 diopter glasses, both of which abolish optic fixation. Nystagmus of central origin cannot be suppressed by optic fixation. Purely torsional nystagmus indicates lesion of the brainstem, vestibular nuclei, and is seen in syringomyelia. Vertical downbeat nystagmus indicates lesion at craniocervical region such as Arnold Chiari malformation or degenerative lesion of the cerebellum. Vertical upbeat nystagmus is seen in lesions at the junction of pons and medulla or pons and midbrain. Pendular nystagmus is either congenital or acquired. The latter is seen in multiple sclerosis. Pendular nystagmus may also be disconjugate, that is, vertical in one eye and horizontal in the other. Table 6.2 shows difference in the nystagmus of peripheral and central lesions. Table 6.1, Degree of nystagmus. First degree, it is weak nystagmus and is present when patient looks in the direction of fast component. Second degree, it is stronger than the first degree nystagmus and is present when the patient looks straight ahead. Third degree, it is stronger than the second degree nystagmus and is present even when the patient looks in the direction of the slow component. These degrees are according to Alexander's law and may not hold true in cases of nystagmus of central origin. Table 6.2, Positional nystagmus in peripheral and central lesions of vestibular system. Peripheral, central. Latency, peripheral 2 to 20 seconds, central no latency. Duration, peripheral less than 1 minute, duration in central more than 1 minute. Direction of nystagmus in peripheral, direction fixed towards the undermost ear. Direction of nystagmus in central, direction changing. Fatigability, peripheral fatigable, central non-fatigable. Accompanying symptoms, peripheral severe vertigo, Accompanying symptoms in central, none or slight. Positional nystagmus is elicited by Holpig's maneuver. Fistula test. The basis of this test is to induce nystagmus by producing pressure changes in the external canal, which are then transmitted to the labyrinth. Stimulation of the labyrinth results in nystagmus and vertigo. How to elicit and interpret? The test is performed by applying intermittent pressure on the tragus or by Siegel's speculum. Normally, the test is negative because the pressure changes in the external auditory canal cannot be transmitted to the labyrinth. It is positive when there is erosion of the horizontal semicircular canal, as in cholesteatoma, or a surgically created window in the horizontal canal fenestration operation. Superior canal dehiscence, abnormal opening in the oval window, post-appendectomy fistula, or the round window, rupture of round window membrane. A positive fistula also implies that the labyrinth is still functioning. It is absent when labyrinth is dead. A false negative fistula test has been seen in surgically confirmed cases of labyrinthine fistula. It is also seen when cholesteatoma covers the site of fistula and does not allow pressure changes to be transmitted to the labyrinth. A false positive fistula test, that is false that is positive fistula test without the presence of a fistula, is seen in congenital syphilis and in about 25% of cases of Meniere's disease and is called the Henbert sign. In congenital syphilis, it is due to hypermobile stapes on inflammatory fibrous bands between the stapes foot plate and saccule or utricle, while in Meniere's disease, it is due to distended saccule lying against the stapes foot plate. Romberg's test. The patient is asked to stand with feet together and arms by the side with eyes first open and then closed. With the eyes open, the patient can still compensate the imbalance, but with the eyes closed, vestibular system is at more at disadvantage. In peripheral vestibular lesions, the patient sways to the side of lesion. In central vestibular disorder, patient shows instability. If patient can perform this test without sway, sharpened Romberg's test is performed. In this, the patient stands with one heel in front of the toes and arm folded across the chest. Inability to perform the sharpened Romberg's test indicates vestibular impairment. Gait. The patient is asked to walk along a straight line to a fixed point. Fix first with eyes open and then closed. In case of uncompensated lesion of peripheral vestibular system with eyes closed, the patient deviates to the affected side. Post pointing and falling. The past pointing, falling, and the slow component of the nystagmus are all in the same direction. If there is acute vestibular failure, say on the right side, nystagmus is to the left, but the past pointing and falling will be towards the right, that is, towards the side of the slow component. Dix-Halpig's maneuver positional test. This test is particularly useful when the patient complains of vertigo in certain head positions. It also helps to differentiate a peripheral from central lesion. How to elicit and interpret. The patient sits on a couch. The examiner holds the patient's head, turns it 45 degrees to the right, and then places the patient in a supine position so that his head hangs 30 degrees below the horizontal. The patient's eyes are observed for nystagmus. The test is repeated with the head turned towards left and then again in straight head hanging position. Four parameters of nystagmus are observed: latency, duration, direction, and fatigability. In benign paroxysmal positional vertigo, nystagmus appears after a latent period of 2 to 20 seconds, lasts for less than a minute, and always in one direction, that is towards the ear that is undermost. On repetition of test, nystagmus may still be elicited but lasts for a shorter period. On subsequent repetitions, it disappears altogether. That is, nystagmus is fatigable. The patient also complains of vertigo when the head is in critical position. In central lesions, tumors of fourth ventricle, cerebellum, temporal lobe, multiple sclerosis, vertebrobasilar insufficiency, or raised intracranial tension, nystagmus is produced immediately as soon as the head is in critical position without any latency and lasts as long as the head is in that critical position. Direction of nystagmus also varies in different positions, directional changing, and is non fatigable on repetition of the test. This is at figure 6.1 Dix-Hallpike manual. Test of cerebellar dysfunction. All cases of giddiness should be tested for cerebellar disorders. Diseases of cerebellar hemisphere causes asynergia, abnormal finger nose test, dysmetria, inability to control range of motion, adiadochokinesia, inability to perform rapid alternating movements, rebound phenomenon, inability to control movements of extremity when opposing force restraint is suddenly released, midline diseases of cerebellum causes wide base gait, falling in any direction, inability to make sudden turns while walking, truncal ataxia. Nystagmus observed in midline or hemispherical disorders of cerebellum include gaze-involved nystagmus, rebound nystagmus, and abnormal optokinetic nystagmus. Head thrust test, also called head impulse test as Halmangi test, is based on vestibular ocular reflex. Patient sits or stands and gazes at examiner's nose. Then his head, which is held between examiner's hand, is suddenly moved right or left. A normal person will be able to fix his eyes on the primary position, but one with a hypoactive labyrinth will show a saccade to the healthy side to correct the eye position to the examiner's nose. Remember, in such cases, head is moved to right or left at random intervals and order. Laboratory tests of vestibular function. Caloric test. The basis of this test is to induce nystagmus by thermal stimulation of the vestibular system. Advantage of the test is that each labyrinth can be tested separately. The patient is also asked whether vertigo induced by the caloric test is qualitatively similar to that type of experienced by him during the episode of vertigo. If yes, it provides labyrinthine origin of vertigo. 1. Modified Cobrac's test. It is a quick office procedure. The patient is seated with head tilted 60-degree backwards to place horizontal canal in vertical position. Ear is irrigated with ice water for 60 seconds, first with 5 ml, and if there is no response, 10, 20, and 40 ml. Normally, nystagmus beating towards the opposite ear will be seen with 5 ml of ice water. If response is seen with increased quantities of water between 5 to 40 ml, labyrinth is considered hypoactive. No response to 40 ml of water indicates dead labyrinth. 2. Fitzgerald Hallpike test. Bithermal caloric test. In this test, the patient lies supine with head tilted 30 degree forwards so that the horizontal canal is vertical. Ears are irrigated for 40 seconds alternatingly with water at 30 degree and 44 degrees Celsius, 7 degree below and above the normal body temperature, and eyes are observed for appearance of nystagmus till its end point. Time taken from the start of irrigation to the end point of nystagmus is recorded and charted on a calorigram. If no nystagmus is elicited from any ear, test is repeated with water at 20 degrees Celsius for 4 minutes before labeling the labyrinth dead. A gap of 5 minutes should be allowed between 2 years. Cold water induces nystagmus to the opposite side and warm water to the same side. Remember the mnemonic cows. Cold opposite, warm same. Depending on the response to the caloric test, we find canal paresis or dead labyrinth. Directional preponderance, that is, nystagmus is more in one particular direction than in other, or both canal paresis and directional preponderance. Canal paresis, it indicates a response measured as duration of nystagmus elicited from a particular canal. Fitzgerald Hall-Pick test. A. Patient is in supine position and head raised by 30 degree to make horizontal canal vertical. B. Position of canal and the direction of flow of endolymph. Horizontal canal, utricle, 30 degrees. Calorigram normal A. B. Left canal paresis. Left canal paresis. C. Left directional preponderance. Canal paresis, it indicates the response measured as duration of nystagmus elicited by a particular from a particular canal, labyrinth, right or left after simulation with cold and warm water is less than that from the opposite side. It can be expressed as the percentage of total response from both ears. Response from left ear equal to L30 plus L44 into 100 divided by L30 plus L44 plus R30 plus R44. Response from right ear is equal to R30 plus R44 into 100 divided by L30 plus L44 plus R30 plus